Dr. Sarah, how are you doing today? It's such a pleasure to meet you.
Likewise, thank you so much for having me on.
Yeah, so we're going to be talking about hormone replacement therapy. Particularly, we're going to be talking about hormone replacement therapy for a demographic of women who we've been told we can't have it, or up until recently, it wasn't even a conversation. We were just briefly talking about how women in their 30s, but also more importantly in their 40s in perimenopause, are being denied the access of hormone replacement therapy, that it's really only for women in menopause. And I even think about the designation of like a menopause hormone therapy, and how I was like, what are we doing that is so not inclusive to supporting so many women who deserve this effective treatment. Talk to me about your own journey, about kind of in the nuance of supporting women, particularly making sure that they had all the tools in the toolbox to feel alive, not only in menopause, but even earlier.
Yeah, definitely. And I love how you said that why these designations that we make, we don't tell men that they're an andropause or periandropause. We're just, if you're not making a testosterone, you can have access to it. And women are the same. Like we don't have to wait for that period to stop. And I think that's where a lot of women are not getting the help because we have something so visible. Whereas men, we don't tell them they have to wait an entire year for their sperm. They can't make any more sperm and then they get testosterone therapy. So really, even if you're in your 20s, like we shouldn't really even put any shame around it. There are a lot of things that cause this drop in hormones, and it could be aging, chemicals, birth control, like a lot of different reasons. And so if you shouldn't feel that you're too young. I think that's really also like a message that women shouldn't get tied up into this, oh, it has to be 10 years before your period stops. Like who knows when your period's going to stop? And it shouldn't be this window or a magical window too. It should be an offering to everyone. And I went, no, because I went through it myself. So I was in my early 30s. And looking back now that I have my tool set and I know what I know, I probably struggled my whole life or in my 20s too. And I probably metabolized estrogen quickly. And, different women do have different genetics and metabolize estrogen and hormones differently than other women too. So you take that into account that we make generalizing statements, but you could be different. But I realized that I wasn't so different but at the time, I mean, we're all talking about menopause now and hormone replacement therapy now. But 10 years ago, when I was going through it, nobody was talking about it. And not only did I feel like alone, but I also felt like I couldn't even reach out to the doctors, that I would be kind of laughed at for experiencing all the symptoms that I was experiencing, there are a ton. So anybody that's going through it, it's like, why does it have to be like 100 different symptoms? Because hormones do regulate everything in the body. So you'd end up getting all these different symptoms. But mine happened postpartum. And I think this is also pretty common. You have a baby and then your hormones drop to zero and you don't quite recover. And you're blaming it on, I associated it with the baby or my fatigue or, okay, I burned myself out of medical school or I'm really tired. And you hit that wall and brain fog and fatigue. And that was like my biggest concern, even though I had everything else going on and I was getting sick all the time. I had immune problems, a lot of stuff that I probably took a while because I thought it was my gut, or I thought I had to change my diet. Thought it was a leaky gut or high cortisol or everything that we think it is. I went down that same journey too to try to solve it. And then when I realized it was hormones, and I think you can see that because I felt great during pregnancy. I probably felt the best that I ever did in my entire life when you have hormones on board. And then you're like, oh, I think that that's really what I'm missing. And when I tried all of the products on the market at 35, 34, whatever, nothing works. It's like spitting into the ocean. I mean, these products are designed specifically for 55 and above and 60-year-old women to just barely help with hot flashes. They're not really meant to be these full body rejuvenation systemic treatments. Right. So I had to build a solution for myself because I refused to feel that old. I was only 35. And I wanted to feel like young and vibrant in my age. So I built something that worked for me. And then I opened up a clinic, and this was 10 years ago. And I started treating men and women. And when I saw the difference, if women realized the difference in how we treat and approach men for hormone replacement therapy versus how we currently treat and approach women, they would be outraged and appalled, and they should be. There's such a gap, and then we're so lacking in innovation, and we're still using outdated creams and pills and like things that we know don't work. We don't even use them in men because they're so ineffective, but we still push them onto women like it's okay and that this is a standard of care. And if this is a standard of care, then we need to reevaluate it. It's pretty poor. So, like as a community, as a medical community, we need to readdress this and offer something better. And we've been afraid for so long, right? So, I mean, I understand why it happened, but it's not an excuse. We really need to move forward and pass like all this misconception and give women a better HRT treatment.
Let's talk a little bit about that. Let's dive deeper into that. So, you unpacked a lot of things. One, that women can be struggling with hormone depletion well before their final period or, menopause or postmenopause. And it can show up a lot different than the classic things that we think about, like hot flashes and night sweats and insomnia and vaginal dryness or, low libido, the kind of the classic symptoms we think about that we used to prescribe Premarin for. And so we know that I'd love to walk back a little bit the Women's Health Initiative. And I've talked a lot about that on the show. I've had other people interviewing on the show, but we really talk about, a halt in innovation for women. That was very much, we have, what is it, 2 generations of providers right now who don't even know how to prescribe poor hormone replacement therapy, let alone innovative hormone replacement therapy. Again, I always think about the smallest dose for the least amount of time to mitigate the most disruptive symptoms is what I still see playing out today. And that we're still in the dogma of unless you have a uterus, you don't need progesterone. So talk to me a little bit about, and I feel like we weren't doing the best job even before the Women's Health Initiative either.
Yeah, we weren't. No, and even the Women's Health Initiative, it's strange how it happened. I mean, it is a little bit weird how they held a press conference and they announced that this caused breast cancer, and it never showed that. The fear and this fear mongering and misinformation could be intentional, and so it is weird how it can continually perpetuate. And even now, people will mention the word cancer in the same like conversation with hormone replacement therapy, and it's like with everything in life, there's a risk benefit. Like if I drive on my car in the highway, it's literally the most dangerous thing I can do is like drive on the highway, statistically. I'm not going to give up driving because the benefits far outweigh the risk of it. And that risk is big. Like I literally could die, well, yeah, like in a car accident. So, but the benefit, I'm not going to give up driving because it allows all this freedom and everything else of the benefits. Any therapy you do, there's a risk benefit as well, right? So nothing's 100% safe, but you have to decide what's the best thing for you in terms of risks and benefits. And with hormone replacement therapy, the benefits far outweigh any risk. And when you look at studies that were potentially showed anything, that risk was with this fake progestin, which is not even a hormone. And nobody mentions that. They always say it was estrogen. It was actually the birth control synthetic progestin that caused that risk. And I don't want to freak anybody out on the call because even then, that risk is so small. Birth control is safe. Literally millions of women use it every day. And they're not in the ER stroking and having breast cancer. I mean, it is like these events are very rare, stroke and breast cancer. And even if there is a risk, the WHO recognizes it's being they actually say very, very rare risk. The risk is so small that we wouldn't even talk about it if we were talking about other pharmaceuticals, like a statin or another medication. So why do we continue to push this like very extremely rare possibility with HRT instead of pushing the extreme benefits, which is prevention of heart disease, which 1 in 3 women die from, or osteoporosis or Alzheimer's, or even just like your mental health, which is like a massive, like this health span and living well. I mean, women live a long time, but they are not living very well.
No.
And so, and you have to wonder about when you have this mismatched information and fear, it is the best way to control a population. And I don't mean it is because women need to understand that this convoluted messaging that they're getting is suppressing them. It's keeping them misinformed and it's keeping them from living probably their fullest potential. They're leaving the workforce, right? They're not as like functional. They're divorcing. Their marriages like are getting impacted. I mean, they need to know that they do need to be informed about it because it will impact their entire life if they don't understand it.
I agree with you 100%. Yeah, although we live longer than men, 25% of our lives are spent in debilitating health and poor health. And that impacts our quality of life. Like you said, our life force is being affected. And currently, $26 billion in lost revenue due to absenteeism and healthcare issues for women in perimenopause and beyond. So, it's having a profound impact on our communities, on our families, and on the world. when
Yeah.
women are not fully supported in their journey.
I was gonna say, well, you heard that saying, if you treat the woman, you treat the village, right? Like
Yeah.
it really does impact the entire family.
I 100% agree. I mean, and we feel that each and every one of us, as you're listening to this right now, think about you, how you are the epicenter of your family. And if you're not feeling alive, if you're not feeling capable or functional, like how that has a ripple effect on everything around you. We know this to be true. We've seen this in our own lives and in our family, in the matriarch of your family. So I'm so grateful that we're speaking on that. I want to talk a little bit about the disparity between, I mean, we know that there's so many disparities between men's healthcare and women's healthcare, but particularly around hormone replacement therapy. You mentioned that in the beginning, we got started about how the way that we're being kind of managed and dosed, the delivery method of hormone replacement therapy, how we even consider it for women is so different than how we consider it for men. Can you break that down for us? Because I think I really want women to understand how we are feeling them.
Yes. And I think everybody's talking about how we're failing them and that we're just telling them that this is normal. It's normal to
Yeah.
be a woman. So I'll take a step ahead and talk about how the actual treatment itself is like failing. So men, like if they have low testosterone, we will pour testosterone on you. We'll give you adequate amounts of testosterone. You can feel like you're in your 20s. We know what those optimal reference ranges are to make you feel that way. We used to believe that they needed to be lower, right? We took this really conservative approach, but this was over a decade ago when we did this to men. We told them, oh, it needs to be like between like 4 and 800. And now we'll push it up to 1,000, 1,500 if they feel well. Like they need to feel well. And we will also understand conversion pathways. We know that testosterone converts into estrogen. Sometimes we want to make sure that doesn't get too high. And we know that men also have progesterone. So we do understand that the sexes have all three hormones and that they're not sex specific necessarily hormones, right? But women, we do not. We microdose them. We tell them like, so even if you can find somebody that will give it to you and not tell you that you're too young or that it's okay to take. So, and then they shame you the entire time, right? And they start you at like the tiniest dose.
Yeah, like a 0.25. Yeah, micro dose.
And hormones are extremely safe. They should be in milligrams. They should be these large therapeutic doses because of the way they work in the body. Where these are not, when even basic pharmaceuticals, like anybody on the call are hearing, if it's those are tiny doses that we work with. Hormones should be more substantial doses. So women are not dosed appropriately. Okay. And then the other thing is that when they start these like microdoses, they'll kind of titrate up, which is a good idea to titrate up, but you're still just doing from a microdose to a microdose to a microdose. And then they tell women, oh, that's it. That's all we can go. But that's not actually guidelines. The guidelines say that there is no upper limit of estrogen. You give her enough estrogen until she can't tolerate it anymore. And then you kind of back off a little bit. So really it's a feedback from her on how much she wants. Right. And you're like, but a lot of doctors are like, that's it. I won't go up anymore. You can't have anymore. It's a little like this gatekeeping. But the formulation is different. So with men, we use a superior formula. We inject it for them. They inject it once or twice a week. We used to give them a cream, right? So men would slather on androgel on their chest, and then we realized that it was getting all over little kids and little kids start growing pubic hair. And we stopped putting creams on men because we know that they do not go through the skin. So only 30% of hormones absorb through the skin. Okay. We don't give them pills because it puts a huge burden on the liver. So I would never give a man. And there's new ones out that go through the lymphatic system. I'm not talking about those ones. I'm talking about the ones that are straightly metabolized by the liver. We don't give them to men because they make bad metabolites and it's toxic. Okay. So we don't give them creams. We don't give them patches. We don't give them pills. We give them an injection. Okay. So with women, this would be difficult, an injection, because they would have to inject a lot and they'd have to do it daily. So it's really probably not an option for us. But when you look at but that's not even the standard of care now is a patch and a pill and a low dose vaginal cream and a testosterone cream and an estriol face cream, right? You're talking 5 different products that they're having to like patchwork together to get the bare minimum. Like you said, like I'll have to give you a patch to get rid of your hot flash because it's not really enough to do anything else. A low dose vaginal cream to get rid of your vaginal dryness. And these are severe symptoms, right? This is like kind of that puppy, like you've waited so long that you have a hot flash and vaginal. What about a 30-year-old who really is like hit a wall, having a lot of gut health issues, autoimmunity, and she needs the hormones, but she doesn't quite have the vaginal dryness and hot flashes, as you mentioned. These products aren't going to work for her. They're not going to be enough. And we know that the orals, as I mentioned, are a huge burden on the liver.
Mhm.
They make metabolites that give you a lot of side effects. Women have a ton of side effects from HRT, and it's not the hormones, it's the formulation, it's the way we're trying to give it to them. So, a take-home message for anybody listening is that it's not just the hormones that matter, it is the way you're trying to get them into the body. And unfortunately, we're all having to turn into hormone experts because doctors are not figuring it out for us. So we are doing it ourselves. So if you kind of know this information, no matter what specialist you go to today, this is a very common regimen that they're going to offer you. And it's not going to be effective for most women. And so a patch, there's so much variability on how it goes through the skin. That's why women are like, yes, it works. And it works for like a couple of weeks and then it stops working. It's because there's barely anything in it to do anything for you. The low dose vaginal cream, that's what they do, is just they don't go into the bloodstream. And we know that the topical creams is also another very popular, like they'll put it here on their forearm or in their thigh area. Only 30%. Progesterone is this massive molecule. It does not go through the skin. The skin is a barrier. So you know where it's going. It's going on the kids. It's going on the pets. It's going on like the bed sheets and the towels and your partner. I mean, it's getting all over the house, just like the testosterone cream for men got all over the house. Why would women tolerate these like subpar formulaic way? They deserve they're sophisticated. They deserve a sophisticated solution too that's effective at treating like everything for them.
Mm.
That's one problem. And we can get into like also the philosophy too, but that's just the formulation problem.
Yeah, I was going to say, I mean, I'll be 46 in a couple days and I cycle oral micronized progesterone. I will always be taking that no matter what. And then I have an estrogen patch. I have a almost 5 year old. And so creams are just a no go. They're an absolute no go. I am constantly cuddling and holding. And so it is a patch that I'm using mainly because that's really my only option in terms of ensuring that I'm not getting hormones all over the house and all over my son. And I will say that at 40 something years old in perimenopause, it's an interesting journey because I have changed. I've been playing with dosing and figuring out dosing because I will tell you that even 2 years ago, what my dosing was is not the same as it is today. And it can be such a challenge to now, even when I know pharmacology and I understand the way that these hormones work, ultimately, I'm really paying more attention to myself and my symptoms than I am looking at numbers, in terms of labs. And so I'm curious, in terms of working with women to figure out what the best dosage is, particularly a woman in their 30s and their 40s, where things are shifting and changing. How would we best navigate that when we're trying to look for a practitioner where a lot of it is very much static dosing and, one size fits all?
And this is the problem, is that it's all static dosing and one size fits all. And so even if you are, the only difference is if you cycle it, but I would argue that this is treating yourself half of the month because you're only doing it half of the month. But the women have this, a lot of this is on very outdated studies of how we cycle at all, really. So we know that women can have like 0 hormones and still have a period. So we do not need this necessarily, this like wave in the way that we think it's happening. Those studies today would not even be published. They'd be like rejected from medical journals because we did them on extremely outdated radioimmunoassay lab testing, which I know that I'm speaking like foreign, but it's like basically we don't even use these instruments anymore in the lab. They're so poor. The analytical sensitivity and specificity, like they don't even work. But yet all of the old medical textbooks that have this like progesterone estrogen cycle and how it's happening in a month, we base a lot of, decisions on it. And we probably need to redo them on like newer instrumentation. So we do know that like everything's peaking at ovulation, but it may not be peaking the way that we think it is too. So I think women are in like this pickle that they are stuck. They're going to have to find a provider that is willing to work with them more and give them. And then I think this is the biggest challenge. Most providers do not do this. So another thing that women will encounter is that they'll get a lab and then they'll just say, oh, my estrogen's normal. Okay. And
the range is so crazy. The range is so big. And so, that's what I'm curious about is I want to talk a little bit about, we've got a camp where tests don't guess. And I love looking at labs. I look at labs every single day. And I'm looking at not just hormone labs. I want to look at inflammatory labs, cardiometabolic labs. I want to look at your cardiovascular. I just want to take all of it into consideration. If we're looking to potentially prevent a lot of this, I just want to make sure I'm treating the whole person. However, we have a camp that says test, don't guess. And then we have this other camp that's like, we just want to mitigate symptoms. It's just about symptom management. And it's so hard to find an in between about what to do. And I know for me as a provider and a woman who also takes them, I'm constantly playing with my own dosage behind the scenes, like I'm on my own N of one. And I think a lot of women are told that they cannot do that. They shouldn't be doing that, it's really hard to work with providers to figure out what is best.
You and I can do that because we can, and so like we can do, but so I think that we have that advantage, but women can't. So the labs, they're limited. And the reason why, so they are useful in a range, like they can certainly confirm, like they're
For sure. Absolutely.
confirm something that you're already thinking. But the problem with the labs, and not you specifically, but providers or like a lot of specialists, they don't get the right ones. And so they want to make it progesterone, and then they don't get an FSH. So they really need to look at all of them together.
Right.
Like, for example, when we look at thyroid, you can get a screening test, like a TSH. We need to also screen, but you got to really look at all of them. Like, so if that TSH is abnormal, you got to look at all the other ones too. Same thing with this hormone set. You get an FSH, you could use that as a screening. And if the FSH is abnormal, and even then, if it's normal, you still got to look at like everything together. And FSH is completely ignored. And if women understood what happened when their ovaries start to fail, the brain has a sensor and it can tell how much is there, and it will start freaking out and releasing this substance called FSH and stimulating the ovary. And when it starts stimulating the ovary, you get erraticness, like you get this spike in estrogen and it looks quote unquote normal, which is why like the labs can be so misleading, because you'll get a normal estrogen but it can't make its main hormone, which is the progesterone. And then another part of the labs is the reference intervals are not well established. So as I mentioned in the beginning, it's like for men, we've established these really optimal reference ranges. For women, it's like they're keeping us down at like 100 picograms per milliliter, which is inappropriate. And really even that upper limit of 500 should be at least what we're trying to get to. But when you look at women in their 20s who are ovulating, it really gets up to 1,000 or 1,500. Like estrogen is like peaking. So we're keeping women very, very, very low unnecessarily. And so that's also a problem with the labs. As you mentioned, the labs are like, even an estrogen of 0 is not flagged. It's like not considered abnormal. And then progesterone doesn't have any optimal reference ranges established. There are like 5 papers in the entire world. Nobody has established reference ranges for progesterone. And the only one that's really well is testosterone, which is like not our main hormone. And then another problem with the labs is that all of them are in a different unit. If you go to Europe or UK or Canada or whatever, it's like they standardize the units. And so when doctors look at, and providers or any provider will look at this, if you get like a progesterone of 6 and then you get an estrogen of 300 picograms per milliliter, everybody assumes that 6 is like not significant. Oh, 6 and 10, it looks normal. I don't know. They just ignore it. I don't think they know how to interpret it. But that 6 is actually 6,000 if you put it in picograms per milliliter. Your progesterone is supposed to be like 10 to 30 times higher than anything else. It is your most abundant hormone. And and then when you use the labs to match it with the formulations that are currently on the market, your problem is the bioavailability, and you can't see that in a lab. So oral progesterone has very poor bioavailability, and it will put your levels at like 10,000. And everybody's like, yes, this is adequate. And only a third of that's really bioavailable anyway. And so you have very poor, and you get a lot of side effects. So even using the labs to follow the formulations can be very misleading. So I always say that symptoms, you can use them, but good providers will know when to not use the labs as well. Like if you still have a patient sitting in front of you, a woman that's like, her labs are completely normal and she's got issues all over the place, like, but it doesn't seem like she's balanced, then it doesn't matter what the labs say, because they're just a point in time, and hormones are shuffled constantly from tissue to tissue and being excreted and eliminated. And you might have just gotten a lab at this like specific point in time, and it's not this measure of what's been going on like all month. Like the FSH is a much better marker. And using that with her feedback, you really have to like hear her, and are the core things bleeding, and are things clearing up for her? And this is not how we tend to practice HRT. Now, a lot of doctors will be like, oh, your testosterone's low. Let me just replace testosterone. And this can create a lot of problems for women because you're not looking at all 3 hormones for her. When men come in, we don't be like, oh, your estrogen's low. Let me give you a little bit of estrogen. And we know how beneficial estrogen is for men. Right. So we replace his dominant hormone and let it just convert, for example, to estrogen. Like even the way that we approach women, it's not a very effective. So women, yeah, unfortunately, you got to like, it's a little bit of trial and error. You got to just work with a practitioner and be informed like, hey, I want to, and it's okay if you want to follow the labs, get the right labs and know that they're limited though. Like know that they're not like the end all be all.
I want to go back to FSH for just a second, follicular stimulating hormone. I always think about if women are being dosed on HRT early enough that potentially their FSH never rises. We never see the rise. What is your take on that in terms of it being an indicator, or where would you love levels to be?
The probably best one that we have now, I would say, and it's really, really underused. And we shouldn't let it get high. It should be this like first sign that the brain is struggling in the ovaries, and that whole feedback loop is like signaling that there's like a crisis, and it should be below 8. So we should be keeping FSH below 8. And women, I hear this feedback from women because they know that like my formulation's a little bit higher dosing, and they get, I don't want too much. I'm like, don't worry. Like the FSH is never suppressed. You just want to keep that FSH between like 1 and 8. And if you have a ton of hormone on board, then it would be suppressed, and you would know that from the brain would tell you that. So it is like a reassurance too for women that they know that if they're keeping it in this optimal range, that they're not doing too much, but that they're also getting adequate amounts. Because I think women are worried about the wrong thing. They come to me, they're like, I'm worried about getting too much. I'm like, you actually need to be worried about not getting enough, because practically it's very hard to get the hormones into the body. So you really need to be like trying to get them in there and keep them around for the full 24 hours. And that's actually the challenge. It's not when women get pregnant, estrogen gets up to 40,000 picograms per milliliter during it's like a fourth trimester, like a third trimester of pregnancy. So like, is that dangerous? I mean, and then we're talking about just trying to get it up past 100, like 100.
Yeah, I was going to say that's
so it's like, it's not even in the same ballpark, women. So like, we're just trying to get it as close to that. Above 100 is actually where, 100 picograms per milliliter for the estrogen for protective. And compare that to the 40,000 it gets to in pregnancy. And so we're not even able to achieve these levels anyway with current formulations. So you don't need to worry about it. You actually need to worry about getting
enough. So curious, because I remember doing all this research, and gosh, it is so outdated. And I was particularly looking, like, there's still an argument that hormone replacement therapy is not neuroprotective per se. Like, there's, or even cardioprotective. We can say safely that it protects from bone loss. That it protects from osteoporosis. We can say safely that it's protecting from genital urinary symptoms of menopause. We can say safely, like, there's not too many areas where we can safely say that it's really doing that. And so, but I remember when I was writing in my book, like, because I feel like it's crazy how they'll just come after you. People just come after you about, you making these statements and these claims. And particularly, I was looking at, I would say that the majority of my patients are really struggling with the brain related symptoms of perimenopause, the cognitive changes. We know that the brain is just doing the best it can to just like struggle its way through perimenopause. And we see an increase in inflammation and a decrease in energy metabolism. And man, it's not setting us up for a great course moving forward. And I believe that my argument in terms of like physiological range is that we need it to be close to 150 picograms per deciliter. And even that I felt fell short. But I was like, okay, there's enough research to plead the case of that. And that would require less than the microdose patch that I'm seeing being recommended most of the time. And so is there a range that, we talk about, gosh, I feel like there's a lot of danger, particularly with the menopause society, when we talk about physiological dosing, like that we should not be dosing women back to physiological range. And that even to plead the case for 150 picograms per deciliter is a stretch at best, because now we're talking about well more than a microdose at this point to get them there. I'd love to hear your thoughts there, because I feel like, especially right now in today's medical society and in today's healthcare in terms of the US, that even pleading the case for 150 seems like a lot for some providers.
Feels so oppressive, doesn't it?
Yeah.
We do not do this to men. Like there's no andropause society that says, no, we can't get testosterone above 150. And so why do we need to prove anything anyway? Like we use hormone replacement therapy for longevity for men. to like feel good, for fertility, for prevention of diabetes. Like, why do we have to absolutely be at it, to protect? Like, if we know physiological levels for young women are 500 at least picograms per milliliter, so we do this for men. So the way we established optimal ranges for men was we gave them testosterone until we suppressed their FSH. And we used that data for FSH to show that this was the brain, not the Menopause Society. Like, thank God the Menopause Society doesn't tell me what my physiological range is, because I would be miserable. But my brain is telling me what my physiological range is, right? The FSH. And we gather data from like hundreds, if there are thousands of women, and then we can tell and we can see what that physiological range is. It's not something that's randomly dictated by a panel. And I actually get a lot of haters too for saying this, but I think it's just oppressing women. We know from a lot of studies that estrogen is needed to clean the CSF in the brain at night, right? This is so protective. Like you mentioned, the oxidative
Stress on the brain. Yeah.
stress in the brain. There's so, like, we don't, do we need a trial for everything? We've not done all these trials on testosterone to show like its benefits, right? We know that women feel better. We know cognitive scores go up when they're appropriately treated with estrogen. And we see the reverse thing happening when estrogen drops and Alzheimer's like goes way up. We have a lot of this information.
I know. I was going to say, we have that data. We know that when estrogen does drop, we see an increase in dementia and cognitive decline, specifically in the female population. And so if that's the linchpin, but we need this research to demonstrate that bringing it back on board is actually neuroprotective. It's just mind-blowing to me.
I mean, you don't need it to to justify HRT though, like, because there's other benefits. We don't actually.
Thank goodness. Yeah. So as long as we have these other benefits, we don't necessarily, but it's interesting to not, the need to be so careful about claiming that it is neuroprotective is a little interesting. I want to just pivot for a minute because, you're talking about physiological doses and you're talking about how we have it's old data in terms of, tracking hormones across the menstrual cycle. And I was curious your take, right? Currently, right now, the standard of care, the gold standard of care for women in menopause, let's just not even say peri, because I feel like that, you have a period. We're not having this discussion. There's hormonal birth control. And curious where you land on that as well. Like, I know for me, I've never done well on hormonal birth control. And as I started experiencing symptoms in perimenopause, it was always going to be HRT. I wanted bioidentical hormone replacement therapy versus a synthetic, especially when I never really did well on the synthetic hormones to begin with. So I'm curious about going back and forth in that in just a second. But in menopause, what we're recommending is static dosing, continuous dosing. Do you have any thoughts about rhythmic dosing? Do you think it's necessary, or do you feel like we're just underdosed in general?
Underdosed in general, but
okay.
There is a rhythm that was still needed, even in menopausal women. And the problem is, like, women will do the HRT and they'll still start spotting and bleeding, right? And then
yeah, absolutely.
So it's better just to keep this rhythm. Okay. If you think about potentially what's happening with the uterine lining, all menopause could be is that it's just the uterine lining is so atrophied that it stops shedding. Like, we get so much vaginal atrophy, we get skin and hair and all this other atrophy, then the uterine lining just atrophies. And so if you are stimulating it still with the hormones, even though it's not like quote unquote a real period because you didn't ovulate, you're still like needing to shed and detox this lining. And when you look at what happening during a natural period, it's not the ovulation that signals the period, which I think is like where this misconception is that, oh, I'm having a regular period, it's normal, which means I ovulated, which means I'm fertile, which means my hormones are normal. This is like the pathway that I see women and doctors.
Well, it's always because we always focus on the period. Well, there's just a lot of misunderstanding about how it all works.
Yes. And so like they assume that they're normal. Yeah. And so, and we've tell women that. I think it's like, it's the very visible thing. And women are like, their whole lives are defined by it, But the fact that half the population goes through it and it's like every month and we still don't know much about it, it's a little bit embarrassing. But when we look at if the egg does not, in a normal ovulating female, younger, if she ovulates and it doesn't get fertilized, the egg, then everything, all the hormones drop to zero and you get a withdrawal bleed. So that period is actually signaled by the drop in hormones, and that's what triggers the bleed. It's not the ovulation that triggered the bleed, it's the drop in hormones. So when you think about hormone replacement therapy and cycling, if you want to trigger that, you can mimic that naturally in your body by stopping the hormones, having a withdrawal bleed every month. And it also prevents this like receptor desensitization, right? Because you're giving a break from all the receptors. So you're trying to keep that rhythm that naturally happens in your body already. The cycling of progesterone 2 weeks and estrogen 2 weeks, there's no science behind. Show me the science. Like, I want somebody to show me really good science that that's actually what we should be doing. I think we're just undertreating women like half of the month. We're not giving, like, we're giving them microdoses already, and now we're only giving it to them half of the month. They don't need this to have a period. They just need to stop the hormones, have a period, start the hormones again. If that's what they're trying to do, is keep this uterine lining healthy, which is the goal, because as we're older, we're not trying to get pregnant. The goal is to really keep
that,
uterus.
Keep that lining clean and making sure
we
that
might detox this way. Like, potentially there's things here that we need to take into account. And then also, the uterus and the breasts are definitely metabolizing hormones. So we need to, we need to take care of these. Like, they're not just girly parts. They're like there for whatever babies. And this is they actually do participate in the pathways of metabolism. So that's my take on cycling. I think that I have tried it, and I just don't feel like, why wouldn't I want to feel great every day of the month? I already have to feel terrible when I do the withdrawal bleed. So why am I going to do it for 2 weeks? You're only feeling good 2 weeks of the month. When estrogen and progesterone completely oppose one another in the body, why would you only do progesterone 2 weeks and then estrogen 2 weeks? Like, they need to be done together. Every process, like, even if you think about blood pressure, the vessels, they have estrogen and progesterone receptors on them. One vasodilates and one constricts. And if if you cycle, you could get headaches. Like, maybe women are getting headaches like in the month, and that's because you are taking one hormone on and off instead of getting these like really stable levels. Again, we're making the assumption that this is happening based on these really old studies. And I would just say that based on my own experience and the women that I've worked with, thousands, they don't feel well when you cycle. They feel unstable because you're not giving them total stability during the month, and you're swinging them, like constantly swinging them. And they feel like they're always chasing that. You're always chasing it, right? Like, even you're kind of like, I'm adjusting everything. You shouldn't have to adjust so much. You should get to these really adequate levels, make sure everything's stable. And you can adjust your diet, and you can adjust supplements and other things, but the hormones should be stable for you so that you feel mentally stable, and your weight and sleep and everything, you get some stability. And things like PMDD, this is a really bad thing to do to swing it. And
I was going to say, with PMDD, we absolutely need to be continuous dosing progesterone. Yeah.
Estrogen too. So
absolutely. Estrogen too.
Estrogen, you're getting a lot of doctors are well, if you're younger, you don't need estrogen, and so it's kind of like this, but really estrogen raises dopamine. And so if you have anxiety, depression, irritability, or insomnia, dopamine plays a huge role in helping you sleep and keeping your anxiety away. And it's not just progesterone that's doing that. So I think we need stability in both of those hormones to feel stable. And you're talking about birth control. It's even the FDA, even the traditional doctors that follow all the guidelines, they should follow their own guidelines then, because the FDA contraindicates birth control over the age of 35. Because of the risks, we should not be giving, and these are not hormones. We call them hormonal birth control because they bind to the hormone receptors, but it is a chemical. It's just this chemical that's made up. And receptor antagonism is not all the same. Like you said, bioidentical, when it's the natural hormone, you're going to get a completely different response to the cell and the body than these chemicals. And it's not when you look at the studies and you're talking about how there's this really conflicting study information, it's because they use these synthetic progestins, and they pull in progesterone, and they're using a chemical, and then they get, a higher risk of Alzheimer's. And then everybody's like, oh, progesterone's going to give you Alzheimer's. And it's no, wait. They need to study the natural hormone too. And they're not doing that. So the studies are not there because we don't study our natural hormones. We study birth control. So there's thousands of studies on birth control, and there's 300 types of birth control, and everybody's told that it's hormones. And so women do need to know that they're totally different.
Yeah, no, I wanted to really emphasize that they are totally different. And yet that's what we're basing all of our HRT research on, is the synthetic hormones, not even real hormones, hence the fear mongering and all the things that we're seeing with that. Curious really quickly, and I get that this is, an individualized approach. You hear a lot about women in early perimenopause, that their estrogen levels are predominantly more dominant, estrogen dominant. And I'm not saying that women don't experience symptoms of estrogen dominance. I'm not going to lie. When I have my patch on, I like at the end, like halfway through my luteal phase, all of a sudden I started getting estrogen dominant symptoms. And so that's what I'm kind of playing with right now. I'm curious. So would you recommend, and I know that this is case by case, but women who are still cycling, would you recommend cycling progesterone? Or even if a woman's cycling, would you bring it on continuously? I think, would it be based on symptoms?
So I don't believe in cycling this way. Like
Okay.
you're just under treating any woman.
Mm-hmm.
So you really need to stop, like have continuous hormone therapy for 28 days, stop it, have a period, and then start again.
Uh-huh. Your
Your progesterone is always supposed to be 10 to 30 times higher than estrogen, or you're going to end up with like some symptoms. I don't think that I would argue that women say they have estrogen dominant symptoms are not actually estrogen dominant, and you can't become estrogen dominant on a patch. Like it's like nothing's there. It's probably because it's low and you don't have enough estrogen. So the estrogen dominant thing, let's talk about it because it is like such a important thing. When we were talking about that FSH and then it overstimulates the ovaries and then it releases a bunch of estrogen, it's not your dominant hormone. Progesterone is that dominant hormone. And so it's true when your estrogen gets up to 1,000 and you don't have any progesterone around, you're going to feel crazy and ragey and like a lot of different symptoms. Okay. But the treatment is not to avoid or lower estrogen. I think that's the misconception that women are like, I need to lower my estrogen or I can't take it. When you start HRT, progesterone, even if you're progesterone only, and even if you only take it the 2 weeks of the month, you're going to suppress your FSH. And when you suppress your FSH, you're going to stop making estrogen because why? The only thing that was keeping you making estrogen was your FSH being like through the charts, making your estrogen. So your estrogen is going to go very low when you start progesterone therapy. You need them both. So even women that have estrogen dominance, that just means your ovaries are failing, girl, and you need to take all of your hormones. Like you need to make sure that you're replacing estrogen, progesterone, and testosterone because your ovaries are not working. So like the labs, all they do is tell you that your ovaries are failing. They're not telling you that you have all of this estrogen around all the time. That's not what they should be saying. So not everybody like really, and then women are denied estrogen for years.
Years. I was going to say the standard of care is we start women on progesterone first, because again, the symptoms often indicate that they look like progesterone driven symptoms or declining progesterone based symptoms. We cycle it. And then maybe we start to bring, I mean, I can't tell you how many conversations I have where doctors are like, I don't feel safe even thinking about it. Progesterone, sure, I'll let her have that, but that's it for a while.
Oh, they don't know. They've not been trained to deal with like when women come back. The problem is like when doctors give them estrogen, women come back and they're like, I had an extra period, and then they freak out. And it's like, okay, it's okay. You're a woman. You have like okay, let's watch and see what happens next month. Like it's a lot of it's helping women with expectations and side effects, and doctors don't feel comfortable because they don't know.
Right.
Like
They feel the
like
liability. They start to like that little red light sign.
from what? You know what I mean? So it's kind of like it's just this like unknown that they're fearing, and it's all fear-based. It's not based on science. There's no science to say that they can't do it. It's just that they literally have like don't know, but they haven't had any training. And they haven't spent the time with women to get that feedback. But the estrogen, like women do not feel well. If they just give them progesterone only, they're going to get vaginal dryness, acne, BO, like greasy hair. They are going to get side effects from it. And that's why everybody's like, well, then they start hunting down all these leaky gut, cortisol, like all these other problems. And not that there's anything wrong with the functional medicine approach. We need to do that too.
It's a yes and yeah.
Yeah, but it's like estrogen is not the thing to avoid. And then when you give somebody DIM and you lower their estrogen even more, you're making things worse. Like why lower their estrogen? It's the protective. Another thing to think about is if your estrogen receptors are free and you don't have any estrogen, then they're free for chemicals to bind to in the environment. We're talking pesticides, plastics, phthalates, fragrances, like all the nasty stuff binds to the estrogen receptor. We call them estrogens, which is also like really damaging to estrogen. It's like a bad PR campaign, but they're not estrogens. They just bind to that. But if you have your
xenoestrogens, that's the kind of
is like a better word. We shouldn't do that because we're implying that it's an estrogen-like, and it's not.
Yes.
What they're doing is they're preventing estrogen from binding. Like they bind to the receptor and then your own estrogen can't bind. So women, if you want to treat estrogen dominance, you should make sure that your estrogen is actually enough that all these chemicals can't bind. And then you have enough progesterone to like counterbalance it. So the treatment is not to lower estrogen, but to actually take it. And then you'll feel better and not to like, again, understand estrogen, not fear it.
Yeah. Okay, that makes okay. Oh, goodness. I know women are going to be unpacking so much, and I'm so grateful. We're going to talk a little right now. I'm going to have you just share a little bit about yourself and where we can find more about you and the company as well, because a lot of what we're talking about a massive narrative that isn't going away anytime soon. I think about in the world right now of hormone replacement therapy education, and I am so deeply grateful we're having some level of conversation around it, but it is also I'm not going to call it harmful by any means, but it's not necessarily helpful in the sense of really giving women what they need for feeling really great besides symptom management. Because that's where we're at. We're at a symptom management position, and that's what we're offering at the moment. And that's what women are getting,
Yeah.
especially with a lot of the telemedicine companies out there or just working with their own provider. If the provider will even give them HRT, it's at such a low dose
Yeah.
of both. I got in trouble. I was working with a pharmacist too. I'm not continuously taking progesterone, I'm cycling it. And I didn't realize I picked up a bottle of progesterone. And I called my pharmacist and I was like, hey, why didn't it come with my estrogen? And I got yelled at. He's like, you have more than enough at the house. Like you should only be cycling it this much. I'm not giving you any more. And I was like, what? And it just that was where the pharmacist landed. And he was like, you can't get any more right now. That's where I'm at with it. And it was crazy. I was like, whoa. So it just even, let's say your doctor is prescribing a due amount. You may even have a pharmacist who's like, no, that's just not what I think to be true.
It is true that pharmacists do have opinion about HRT, the company pharmacist, and you're just like, dude, like you, yeah. So some of
I
them
felt
are
like we got slapped on the hand.
it's over the counter. I mean, you could get this like progesterone is like it should be over the counter.
Yeah, no, I know.
I cannot even, what is like a dangerous substance here. Yeah, it's really strange. And you're right. There's variability. Like that's the problem now is that the standard of care for men is standard. You go everywhere, you get the same thing. Like no matter what provider you go to, they're pretty much going to do it the same. You go to the pharmacy, you're going to get the same response. With women, you go to 10 different doctors, you're going to get 10 different answers. And like
Yeah,
anybody,
no, exactly.
even the products are different. So you're totally right. So we offer something online that can potentially give some standardization for you, like you can get a predictable product and predictable service and know what you're getting. And it's at innerbalance.com. And we're in 48 states, so you can sign up. We don't require labs or things to start. But if you want to change the dose, and certainly we follow you. So we have a clinical team that makes sure that you're doing well. You can meet with us at any time. And we help you with the side effects. So side effects are really common with any HRT. Our formulation has less. But 10% of women are still going to get bloated,
Yeah,
right?
for sure.
Like digestion
Absolutely.
issue. Like you might have water retention. You are going to have breast tenderness. You're going to have cramping. You might have, like, if you have anything going on, we're going to help you through that. So even though it's an easy kind of way to get in and try something, and because you're an adult and you can try something if you want, but certainly like work with us in order to make any changes or to make sure that it's right. Or even if you want labs, we'll help you with that. So a service that can get you optimized. And it really is a 6-month journey. So women, you're not going to get it on the first time. You've really got to get on a starting dose. As I talked about that titration, you start lower and then you have to go up over time to make sure that one, you don't bleed, you don't have a lot of bleeding, your uterus is good, your breasts feel good, like everything is feeling good before you go up in dose. So it still is important to take it step by step. I know a lot of women come to us and I've been like, I've been suffering for years and I want to go up to like what I should be at. And you're like, you still have to go
You've
through
got
the
to titrate the
yeah.
process. Yeah, agreed. I agree with you. Yeah.
Yeah. So, but we use a formulation that it bypasses the liver metabolism. So you're not going to get the side effects of like sleepiness during the day. You can stop it to have a period. So it's really this, like, you can still cycle and not mess with that. You can still get pregnant on the cream. So we're like advise women to be careful because we have a lot of younger women in their 30s and 40s who are still in pregnancy window. So we're not impacting ovulation with it. So just be careful of that. But really it's like 30 seconds a day. So you don't have to do like 5 different things like on your body just to try to get some relief, which is chasing labs, for example. We can, but it's exhausting and you can try to just get some stability without a lot of lab chasing.
Sarah, thank you so much for joining me today. I'll have all the links in the show notes. Anywhere else you want us to find you?
No, I mean, my social, if you want even just information and you're just not even sure, you can come to the website or Inner Balance MD, like on Instagram. And we try to we can answer your questions there and give you information there too.
Perfect. Thank you so much. Thanks for this beautiful conversation. Thank you so much for watching. Now, if you found this video helpful, give it a thumbs up and share your thoughts in the comments. And if you are ready to learn more about perimenopause and how to navigate with a lot of ease and grace, be sure to subscribe to this channel so that you can join our community. Don't forget to share this video with someone that you love, that you know is navigating the perimenopause journey as well, because they deserve to feel their best too. See you in the next video.